has and continues to have a severe impact on planned surgery in the UK. And dealing with consulting backlog is a critical concern for the NHS. Recently published statistics indicate that 4.7 million individuals are still waiting for routine operations and procedures. Simon, are you able to kick us off this afternoon and talk our viewers through the situation faced by West Hertfordshire?
Yes, certainly. So we started the sort of COVID journey, if you like, back in the middle of last year. And we started that journey with a pre-existing problem. We already knew we needed a digitized preoperative assessment pathway.
Every trust really that we're working with across all our platforms, I think the challenge is the same, and it's going to be a challenge that we're facing for the next 4 or 5 years possibly to recover. Because I think the key is that even prior to the pandemic, the waiting lists were excessive and were rising, and there were a proportion of patients who are still waiting longer than 18 weeks, and in some cases longer than 52 weeks for treatment. And so I think we were already, as the NHS in many places, struggling almost to keep up with the required capacity and the required workload that was coming through. Adding on to that, the impact of the pandemic, I think that some recently published evidence, sort of in terms of modelling work, has suggested that to clear just the new cases that have developed over the last 18 months or 15 months or so since the pandemic began, you'd have to work at 180 to 190% of pre-COVID or pre-pandemic capacity. And given the levels that we were already working at to achieve those things, and the level the trust were already working at to achieve what sort of the status quo, I think that expectation is something that we're going to have to be dealing with for a long time. And I think most trusts that we're speaking to have got the same problem that was faced by West Herts. And I think taking a step further, it comes down to visibility, and it comes down to, as Simon says, understanding, which patients are fitting where on the priority, understanding where the harm review process fits in to make sure that patients who do need to be more prioritized higher are prioritized, and that visibility is given to people, in the decision makers within the trust, to be able to then facilitate the additional capacity required to treat the patients who need the treatment the most.
So we worked quite closely with Open Medical. We had a pre-existing relationship with them for a different software product, and they introduced us to PathPoint, which was very good at being able to solve 2 problems in one go, and subsequently a number of other problems that we've encountered. So we instantly digitized our preoperative assessment process. That was a win straight away from our perspective. But we also were able to add the 6,000 patients on our PTL into the PathPoint system and give them a P category status, which has allowed us to then live track what was happening with the remaining patients who, if you like, were our elective patients. As the process has moved on, viewers will understand and know, of course, that we've developed a system of what we call harm review processes. This is very topical at the moment. And Open Medical have worked with us to adapt our PathPoint system so that we've now added in a harm review process into the actual software platform. So as well as doing the P category right at the start of placing the patient onto the system, we are now retrospectively going back into every single patient and reviewing them at set times. That set time can be manipulated. It can be manipulated so that, for an orthopedic procedure, it could be a harm review at 40 weeks. But say for an ophthalmology procedure, it could be a harm review at 18 weeks, which is a more delicate and refined surgery, for example. That's flagged instantaneously, so that comes through as an email to either a manager, or it can go directly to the clinician, but we've opted for it to go to the manager because the clinicians can be slightly askew at looking at their emails. And we can get live updates on how our harm review process is going and know exactly what's happening with the patients. I mean, in West Hertfordshire, we have at the same time as this, we have been working with a provider to institute an electronic patient record. And there's great faith in store in what our electronic patient record is going to do for us. But from a management perspective, certainly from a divisional perspective, from my point of view as a divisional director, And also from sort of the point of view of our performance director and our chief medical officer, it's about visibility of what's happening. So certainly within West Herts, there's been a lot of concern mainly about the harm review process and how we can gain assurance that we are actually conducting meaningful harm reviews. Harm reviews weren't something that has been invented as a consequence of COVID. They've been around for a long time. They were around 4 or 5 years ago. They were here pre-pandemic, and we didn't have to do that many of them, thankfully. But the whole of the COVID situation has meant that we're regularly going to have to do a lot. So, for example, I know that from an orthopedic perspective, I've got 183 outstanding harm reviews to be conducted. And Michael and his team have worked quite closely with the orthopedic department to build in the harm review process, which is clinically led and meaningful, so that the patient can actually be physically reviewed, new radiology investigations instituted if necessary, and then a proper harm review undertaken on a clinical basis, such that the outcome and the relevant change to the P category status, where the British Orthopaedics Association have been quite rigid about this, quite rightly so as well, is a meaningful outcome. That's useful not just to the orthopedic surgeon and the patient. The patient, obviously, because they're going to get their surgery in a more timely fashion if necessary. The orthopedic surgeon, because he actually understands and can demonstrate that he's conducted a harm review. But from a trust perspective and an organizational perspective, it allows us to demonstrate openly on a software platform that something's being conducted in a timely and meaningful fashion.
That's been done across various software suppliers, looking at managing preoperative assessments, looking at streamlining it. It's really multifaceted. I think there's an aspect to pre-screening patients. For example, you'd always have a cohort of patients who are young, relatively fit and healthy, and don't need a sort of full-on formal pre-assessment. Can typically have basic blood tests if required, basic observations, swabs, and get assessed on the day of surgery by an anaesthetist, thus increasing the capacity available within preoperative assessment clinics for those that require it more. So there's definitely an aspect of pre-screening, but you've got to get that aspect right, because if you try and automate it too much, try and have a system do it too much, you end up going too far the other way, where a system's not going to take responsibility for potential patient risk, and so you end up with an even higher proportion of patients seeing an anaesthetist than potentially would be required. So you have to find a balance. You have to find a sweet spot between gathering the correct information beforehand and having someone clinically triage that to assess which patients are more suitable for an anesthetic-led pre-assessment, which patients are more suitable for a nurse-led pre-assessment, which patients are suitable to proceed straight to surgery. Taking it a step further, the reason to optimize that and the impact that has on the rest of the theatre capacity is around the context of pre-assessment. And I think that's maybe where the work that we've done with West Herts has really tried to bring that to life, in taking the preoperative assessment in the context of the entire patient surgical pathway. A patient who is on the waiting list for a major bowel surgery for colon cancer, and is also on the waiting list for a carpal tunnel decompression under local anesthetic, are having two completely different operations, two completely different priority levels, two completely different harm review assessments, and two completely different preoperative assessments associated with it. And by giving the context to the preoperative assessment within the remit of the actual procedure that the patient's on the waiting list for, you give the preoperative assessment team the ability to facilitate and triage appropriately, and you give the scheduling admissions team the ability to choose the right patients for the right list at the right time. So putting all of that together in an end-to-end pathway means that if I'm the admissions scheduler and I have a short notice cancellation in a week's time, let's say under Simon's care, I want to know who's available at short notice, who is a relatively high priority patient, who has to self-isolate from a COVID risk perspective of less than 7 days, because that's the only time period I've got, who has also passed pre-assessment, and let's assume it was on a cold site operating unit rather than in the acute site. I need to make sure they were suitable for that. And on my on Simon's waiting list of 400 patients under his care, I need to be able to filter the 5 that meet those criteria. Low risk, day case, self-isolation, 7 days, ready pass pre-assessment, and can attend at short notice. And by having all of that information contextually available around the pre-op assessment, around the surgical pathway, all linked, I can filter it down to the 5 patients that I'm going to phone to see who's available to come on that list next week. And so that's how you bring it all back together and utilize it to maximize theatre efficiency, because you're able to fill lists at shorter notice. You're able to have visibility over, where is the capacity. If something is, if a patient has to cancel at short notice because they've tested positive for COVID, or because they have, a relative who can't bring them, or they don't have care at home, so on and so forth. How do we maximize the available capacity to try and go back to what we were talking about functioning at 190% of pre-COVID levels? You really have to eke everything out of the system that we can. And I think the visibility and the contextual visibility of the entire waiting list, including COVID risk, harm review risk, preoperative assessment, and waiting list status all in one place, gives you the ability to do that and maximize theatre utilization as best as possible.
Thank you. Simon, just coming back to something that you mentioned just now about your EPR and your transition to a new EPR at the moment. Is this a solution that you see should sit alongside the EPR?
Yes, well, I think there was a lot of anxiety early on because ironically our EPR journey in terms of West Herts was accelerated as a consequence partially of the pandemic and partially as a consequence of an opportunity that arose with another local provider. And that really has been a worry for our EPR sort of team, as it were. They have had to look at all of the systems that we've had and make decisions about what can stay, what should go, what would we have to keep because it works, it is unique and has a unique sales point that allows us to say this must stay because we can't do without it. Now, Pathpoint on EPOA and another part of that whole software package was looked at quite closely. We've looked at what the specific aspects of our EPR have to offer. They don't have the same thing. They can't. Our EPR can't do most of the things that the Pathpoint system can do. But importantly, it won't do the harm reviews for us, and it won't do the P category status for us. That led initially to a degree of anxiety, I think mainly because we wanted to have an EPR that was as trimmed down as possible so that we had very few external providers still attached to the system. But once there was an understanding of the ease of linkability into the EPR that we had, and that had been tested by yet another of Michael's utilisers elsewhere south of London, that anxiety went away. So the Pathpoint system is going to stay as part of our EPR, and it's going to continue to use it's used now across the whole of the surgical division. So every surgical patient goes on to it, and I don't think I could manage to persuade our surgeons to take all 6,000 patients off and put them on something else.
I think so. The way our Pathpoint system works is it's clinical workflow based. That's the idea that the clinical workflow, one step leads to the next, leads to an action. There's linkage between the different pathways. So, for example, as a surgeon, I would go and add a patient onto my waiting list. That automatically triggers the contextually relevant preoperative assessment, and the patient remains on the waiting list in a pending state as not ready for surgery because they haven't passed pre-assessment. Because the pathways are linked, the moment the patient is deemed by the pre-assessment team as having passed pre-assessment, the waiting list card automatically changes. I mean, we use a color coding system. It changes to orange to suggest that the patient is now ready to be listed and they've therefore passed reassessment. And that comes from linking pathways. And each different, each team of users have their own workflow that's relevant to them. So the surgeons would work through their waiting list broken down by specialty or by consultant. The POA team would work through the POAs, again, broken down by priority or date that patient was referred sort of for POA assessment. and the admissions team would work from their work list of those who are ready and unscheduled, those who are waiting sort of pre-assessment and therefore aren't ready to be scheduled yet, and so on and so forth. And so having a workflow system is very different to an EPR. An EPR is very much designed and very good at documenting events, documenting episodes, documenting notes, operation notes, clinic assessments, so on and so forth. And I think what we've tried to do is address a gap in the market around clinical workflows to say, when the system isn't designed to replace an EPR, in fact, it's designed to supplement and complement it and fill in the gaps that maybe EPRs from their inception were not designed for, which is around sort of clinical workflows, user-specific or team-specific work lists, linking across multiple complex pathways.